Hello everyone, thank you for giving me the opportunity to share our research. I'm Yang, working in the Department of Neurosurgery at Shanghai Six People's Hospital, affiliated to Shanghai Jiao Tong University School of Medicine. I finished the research in University Hospital Zurich and Cantonal Hospital St. Gallen, and obtained my PhD degree from the University of Zurich in 2022. The topic of my talk is self-entry neurons into brainstem and direct brainstem stimulation. First, something about the brainstem. We know that the brainstem is a part of the central nervous system. It includes the midbrain in the upper part, pons in the middle, and the medulla in the lower part. The brainstem connects the cerebellum, spinal cord, and the posterior cerebellum. There are 18 of nuclei, including 10 motor cranial nerve nuclei and 8 sensor cranial nuclei, as well as fiber tracts in this area. The brainstem controls subconscious body functions like breathing and swallowing, maintaining the heart rate. Regarding the surgery on brainstem, although we have various approaches like OZ, transnasal, midline posterior fossa approaches for accessing to this area, and assistive technology like MEP, SEP, functional and intraoperative MRI. There are still problems to be solved in terms of the safety of brainstem surgery. Therefore, we have focused our study on improving the safety of brainstem surgeries. First, study on brainstem self-entry neurons. It has been published in Neurosurgical Review in 2018 titled as Analysis of Self-Entry Neurons into Brainstem. We know that there are many proposed self-entry neurons, but they are still disputable. For example, the intercollicular region. Some people say cut in the dorsal midline of the midbrain, while others say don't in the middle, either below or above this area. In our study, based on the Oxford Evidence Scale, we aimed to establish an evidence level for each of the self-entry neurons. It was hypothesized that most of the proposed self-entry neurons have limited evidence. After analysis, we found that there are 27 clinical studies reported 21 self-entry neurons in the brainstem, but only 4 entry neurons have been reported in over 25 clinical cases. Here's the results in detail. We divide the self-entry neurons into 3 categories. The first one is case report. If the entry neuron has been reported in no more than 5 clinical cases, indicated by red lines and shapes. The second one is limited evidence. If the entry neuron has been reported in over 5, but less than 25 clinical cases, indicated by blue lines. The third category is credible evidence. If the entry neuron has been reported in over 25 clinical cases, indicated by green lines and shapes. So here, 12 entry neurons were classified as case reports, including 3 in the midbrain, 5 in the pons, and 4 in the medulla. When we take this away, we have 5 entry neurons classified as limited evidence, the blue lines here, including 2 in the midbrain, 2 in the pons, and 1 in medulla. When we take them away, only 4 ancient neurons left, which are ancient neurons reported in more than 25 clinical cases. They are supra-infracollicular in the midbrain, supra-infrafacial triangle neurons in the pons, and the posterior median circles in the medulla. In addition, all these 4 ancient neurons are in the dorsal midline. We further analyzed how many neurosurgical centers have reported each self-ancient neuron. Our results show that only 6 ancient neurons have been reported by more than 3 different neurosurgical centers, which are anterior mesencephalic neuron, supra-infrafacial triangle neurons, pretrigeminal neuron, lateral pointing neuron, and the posterior median circles. 6 ancient neurons have been reported by 2 different centers, which are lateral mesencephalic circles, median circles, supra-trigeminal neuron, lateral medullary neuron, retroolivary neuron, and olivary neuron. And the rest 9 ancient neurons have been reported by only 1 center. Then back to the 4 ancient neurons in the dorsal midline. As we know, there are nuclei and crossing fibers in this area. And in 1995, Professor Bricolon has mentioned that no ancient neurons in the dorsal midline. Therefore, our conclusion for this study is that the safety of self-ancient neurons into brainstem still needs more clinical evidence, especially validation from different neurosurgical centers. As mentioned earlier, the proposed self-ancient neurons are not 100% safe, especially when the anatomical structures have been displaced by the lesion. In addition, direct stimulation has been reported for mapping the nuclei during brainstem surgery. But there still lacks evidence for fiber tract mapping. In this study, we aimed to see if direct stimulation is also helpful for corticospinal tract mapping, and to explore the association between stimulation intensity and the distance from the stimulation points to the corticospinal tract. It was hypothesized that positive stimulation with 2 mA indicates the distance of less than 4 mm. This study has been published in Neurosurgery in 2022, titled as Mapping and Monitoring of the Corticospinal Tract by Direct Brainstem Stimulation. How we stimulate intraoperatively. We use classical transcranial electrical stimulation to monitor the MEP signals in the arm and the leg muscles. Then we use monopolar probe with 2 mA to stimulate around the roots of the 5th, 7th, and 8th, as well as the 6th nerves. In some cases, we also stimulate on the floor of the 4th ventricle or on the surface and in the surgical cavity of the lesion. At the same time, we collect the MEP signals in the arm and the leg muscles. Once there are positive MEP signals, we decrease the stimulation intensity to 1 mA or even lower to refine the localization of fiber tracts. After surgery, we reconstruct the fiber tracts based on DTI images and measure the distance. Moreover, we evaluate the patient's outcomes, including neurological condition and muscle strength. In this study, we have included 30 patients with 30 lesions within or next to the brainstem, including cavernous malformation, vestibular schwannoma, meningioma, and so forth. All the patients underwent pre- and post-operative evaluation, including MRS, ipsilateral and contralateral muscle strength, and the corticospinal tract status in MRI. Here, 0 means normal, 2 indicates deviated from normal path. 3 means deformed of the tracts, and 4 means interrupted fiber tracts. These slides show how many stimulation sites we have collected. We stimulate 145 sites anterior and posterior to the root of the fifth nerve. We had 114 sites around the sixth nerve, anterior and posterior to the root of the 7th and 8th nerves. We got 88 stimulation points. On the floor of the fourth ventricle, we stimulated 326 sites. And on the surface or in the surgical cavity of the lesion, we got 236 stimulation points. As shown in this table, we found 284 positive responses points when stimulated on the floor of fourth ventricle and in the surgical cavity. We then calculated the overall sensitivity and specificity between the stimulation signal and the distance of less than 4 mm. The sensitivity was 84.3% and the specificity was 100%. Therefore, the association between stimulation intensity and the distance from the stimulation points to the corticospinal tract is 2 mA, means the distance of no more than 4 mm. In this case, this 62-year-old woman was diagnosed as multiple intracranial metastasis with a large one compressing the floor of the fourth ventricle. Intraoperatively, we can see part of the right pica and the vertebral artery. We use 2 mA to stimulate in the area below the right pica and between the vertebral artery and the dorsal midline. The positive response area is around 7 mm wide. Then we decrease the intensity to 1 mA. The positive response area is about 2 mm wide. We can see this area matches the anatomical structure very well. After surgery, we reconstructed the corticospinal tract and mirrored the distance at one level below the right pica. We can see all the stimulation sites with positive responses have distance of less than 4 mm. In the second illustrative case, this 57-year-old woman had a tumor in the fourth ventricle. Intraoperatively, after removing the tumor, we can see the pica on both sides and the obex, the black star here. We used the 2 mA to stimulate on the surface of the medulla. The positive response area was around 3 mm wide. Then we decreased the intensity to 1 mA. The area was about 1 mm wide. The intensity of 0.8 mA was the lowest level for detecting a positive stimulation signal. After surgery, we reconstructed the corticospinal tract and measured the distance at the level of the left pica and the level of the orbex. We have the distance also support that all the stimulation sites with positive responses have distances of less than 4 mm, while the stimulation sites with negative response have distance of over 4 mm. Therefore, our conclusion is direct brainstem stimulation can be used for mapping the corticospinal tract intraoperatively. We can use direct brain stimulation to preserve the functional and structural integrity of the tracts with knowledge about specificity and sensitivity of direct brain stimulation and the approximate distance. Thank you for your attention.